last in the long series of classes that we are having on hernias. I'm going to keep my video on. If we do have a problem with bandwidth, if my voice, if you should lose my voice while I'm talking, tell me and I'll turn off my video. So I'm going to share my screen. Tell me if you can see my screen, please.
Yes, sir.
Yes, sir.
Thank you. Thank you. Right. Now, today we are going to discuss internal hernias of the abdomen. Now, the important thing is to realize, why do we have internal hernias? You have to remember that as the fetus develops, what happens is the large bit of the mid-intestine, the part that is supplied by the superior mesenteric artery, actually extends into the vital intestinal duct, forms the small intestine, forms the cecum and a better part of the right side of the right colon, and then finds its way back. And it's important to realize the way that the intestine rotates. So we start off with the rotation of the intestines. See, at 5 weeks, the fetus develops. There's a small bulge that gets into the vital intestinal duct. And remember that what is the axis for that small bulge? It's the superior mesenteric artery. And this is what happens at week 5. Then what happens at week 6? It extends and it extends. And then what happens is it undergoes a period of rotation. And it's a rotation that happens in an anti-clockwise direction. See, what happens is when we go through, it rotates. The one that is coming, the foregut leading to the midgut, rotates to, let's say, from the 12 o'clock, it rotates to the 9 o'clock position. Whereas the portion that is going to develop the cecum and the ascending colon migrates from a 6 o'clock position to a 3 o'clock position. So you can well imagine that that rotation is actually happening in an anti-clockwise direction. Okay, so that's the way it develops. Okay, but there's something else that happens. It's not just a rotation. What happens in addition to this is that this part develops into the small intestine. You can see the folds developing out here, whereas out here the cecum develops. Now, just remember, there are 2 points where the intestines are stuck. Where are they stuck? Hang on, let me just get this. Let me get this color. See, it's stuck up there. Let me take the white color, it actually shows up better, and stuck out there, right? And it rotates. As it rotates, what happens is you have the intestine, the rest of the intestine stuck to it. So what basically happens is this part rotates as well, and this part is, I think I better choose a brighter color because it's not going to show up otherwise. So that is the stomach, which used to lie straight. But as it rotates, this also rotates, and this rotates in a clockwise direction to anticipate for that, to compensate for what's happening out here. So this rotates, this is rotating this way, and to compensate, this rotates this way. Okay, so what was front becomes right, what was posterior becomes left. Okay, so you need to remember that. Then what happens is, as we go along, it rotates a bit further, rotates like that. Now, you can well realize that this is a 90 degrees turn. Okay, this is a 90 degrees turn up till here, anti-clockwise. But it carries on. It carries on to the point that this actually rotates a bit further down. So it goes up to a 270-degree turn. And it rotates around what? It rotates around this particular structure. And what is that structure? That is the superior mesenteric artery. If it rotates around that, so what happens is this part of the intestine now lies posterior behind the superior mesenteric artery. So if I were to take you through out here, that is how it forms. And when it does that, that part of the intestine now goes squarely behind the superior mesenteric artery. And you can realize that is the junction between D2 and D3. Okay, which is why you have the uncinate process, which is why you have the superior mesenteric artery and the superior mesenteric vein crossing the junction between the D2 and the D3. So that is the reason that it rotates. So it doesn't finish there, it goes a bit further. And as we go further, that rotates in. And the cecum now comes down, it comes in into from the vital intestinal duct. It was here, what was basically out here, now slides down and sits in the right iliac fossa. So in effect, you have a normal rotation of the intestine. You have the, the foregut being supplied by the celiac, the midgut being supplied by the superior mesentery. So therefore, because that of that 270-degree rotation of the small intestine, you have the major part of the small intestine going behind the superior mesentery and sitting out here, which means naturally that the superior mesenteric now traverses across the junction between D2 and D3, but also that the transverse colon, you recognize it's going to lie squarely across that part, and the DJ flexure now has to travel under the transverse colon. And you can well imagine now, if I were to take you back to that point of fixation, what was the point of fixation? That and that. Now, let's see what were those 2 points when we actually rotate this fetus and we come to a normal position. So that is the normal position. Now, if I were to show you what are the point of fixations, so let me choose the color white. That is the point of fixation. And we know that in life as the, phrenicocolect ligament. And the other part is fixed out here. What is that other part? Let me put in the other structures. If you put in the other structures, you'll recognize what lies out there. So what we do is put in the liver. We've put in the pancreas, and the pancreas develops now from the dorsal segment and the ventral segment, which has rotated behind. So that also in that process of that 270-degree turn has rotated behind the superior mesenteric artery, as a result of which that is the part that largely forms the uncinate process. So what is the other point of fixation? Let's put in the other structure. That is now the other point of fixation. So that is basically the ligament that goes from the liver to the duodenum. It's called the hepatoduodenal ligament. Okay, so you have the phrenicocholic ligament out here, the hepatoduodenal ligament out here. And there's another point that it starts fixing. What is that point? The point where the duodenum now comes into the small intestine, and that is called the ligament of Treves. So these are the points where the intestine stays fixed. That is a secondary fixation. The primary is the phrenicocholic ligament out here and the hepatoduodenal ligament out here. So if we now take it a bit further, so that's the spleen. So now we have the stomach. The stomach, originally the anterior, the lesser curve was anterior. It's rotated clockwise. That has rotated anti-clockwise. So now you have the anterior lying to the right and what was posterior lying to the left. So the greater curve lies flat. Now, because of this, there was a peritoneum which covered the stomach. So when it rotates in, it forms a pouch. a separate pouch, and we know that pouch as the lesser sac. We'll come to that later as we go through. Right. Now, there is another problem. Let's suppose during the course of the rotation, that forms the small intestine, that's forming the cecal bud. And then what happens is it rotates 90 degrees, it rotates in. Now, that cecum is now held by some bands out here. Let's draw it in green. And we have these bands out here which are used to attach it. Now what will happen is it should have migrated down out here, and the attachment is there, which is the lateral paracolic gutter. Okay. But instead of doing that, sometimes what happens is the cecum migrates. It migrates down out there. In migrating down out there, what it does is it pulls that band across, a bit further across, as a result of which that band now travels across out here. Okay. A bit further, it's called the Ladd's bands. Okay. And if you take it a bit further, it can constrict across the second and the junction of the third part of the duodenum, leading to a dilatation out here, leading to an obstruction. So that is what you have in a malrotation. See, the things that happen in a malrotation, because that cecum was originally supposed to go down there, it's gone there. So it's drawn that band across. It's the second and the junction of the second and the third part of the duodenum. Depending on how strong the band is and where the band is, you could have a non-bilious vomiting, as in a typical gastric outlet obstruction, or you could have a bilious vomiting if that blockage was lower down. But more importantly, something else happens. See, now where's the point of fixation? You have a point of fixation out here, and that band is completely stuck out here. Now think about it. That is completely free. It's a sort of a, band sitting out here, two parts of the intestine. We've got one set of intestine out here. That's a recipe for disaster. I'm cutting out, I'm not putting in the multiple loops of intestine. Now, what happens normally is that now, because you have a narrow band, it can twist. And this twist is now, that twist is clockwise. Okay. Now you have a clockwise twist, and you can have a middle bowel, mid-gut volvulus that happens. And when you have that, sometimes what happens is you land up with a situation where you're in, this child is in an emergency, and you have that, you can see that rotation happening across that band, that's a rotation. And that rotation is almost always clockwise. So you have to do an anti-clockwise rotation to derotate that bowel. So what is the operation that is done? That's the Ladd's band. So obviously you've got to derotate it, and the process of derotation is doing an anti-clockwise rotation. So the second stage is what you do, you cut the Ladd's band. Now, when you cut the Ladd's band, what happens is, let me take that color. That was the duodenum. Okay. The cecum was situated somewhere out here. It hasn't been allowed to completely go away. So now you've cut the Ladd's band. Okay, so we cut the Ladd's band. We cut the Ladd's band. But now what happens is there's a fair bit of narrowing between that part and the duodenum and the cecum. So now what you actually have to do is you have to score that, which means you cut the anterior layer. You cut the anterior layer and allow the cecum to slide down. So when you have a Ladd's band, number one step, diagnose, exploration. On exploration, you cut the Ladd's band as number one. Number two is you do something, you do that. You do actually score the anterior part. When you score the anterior part, you cut that and you allow the cecum to move away from the duodenum. That's a vital piece of part of the operation. If you don't do that, you're almost certainly going to get another blockage out here again. So you have to cut that part and allow the cecum to move down.
Sir, can you please tell from where to where lad bands will be attached?
Yeah, sure, of course. Let me take it to the first one, okay? The slide before this. Where is it attached? It's attached from the right flank. Sorry. It's attached from the right flank. That's the right flank. Hang on, let me get some. That is the flank. Okay. Ideally, what would have happened is that cecum should have migrated down out there, and what you would have had was the attachment of the hepatic flexure and the ascending colon to the side that forms the paracolic gutter. Okay. So instead of doing that, what it has now done, it's dragged it all the way out here across the second and the second or sometimes the third part of the duodenum, and the cecum has actually migrated out here. Now what happens is you have a band which stretches across. That's the first stage of that you have, and that causes an obstruction to the duodenum. And you also have a narrowing of the mesentery, because it's never been in life, it has never been, the cecum is very close to the duodenum, so it's narrow. So therefore, now what happens is, if I take you to the next slide, see what was there was basically, now I've drawn this in white, so I'll choose white. The cecum was actually out here, okay? So that was the appendix, that was the cecum, and that was the small intestine going out here. I'll just make it slightly thicker. So that's the cecum. Okay, and the lad's band now stretched from the cecum to the right flank. Get it?
Okay, sir.
Across the duodenum. So basically, once you've cut that, let's suppose we've cut that. Now what happens is we've cut the lad's band. The cecum doesn't follow. Why doesn't it follow? Because that part is very narrow also. So what do you have to do? You can't cut it across. If you cut it across, what will happen? If you cut across that, you're going to spoil all the blood supply to the ascending colon and the cecum. So what you have to do is you have, let's say, that is the duodenum, that is the cecum, so that is the small intestine falling out here, that's the appendix, that's the rest of the cecum, that's the what should have been the splenic flexure, and that is leading down, descending colon into the anorectum. Okay, so what you now have is an area where there is a fair bit of narrowing. You've cut the lad's band, we've cut the lad's band, okay, but there's some bit of narrowing out here. And what you do is you divide the anterior wall. You divide the anterior wall, and once you divide the anterior wall, you try and tease it so that you open the blood vessels. So you've got any mesentery has two layers, isn't it? That's the blood vessel, and you have two layers. You have a layer in front, okay, and a layer behind. So what you essentially do out for this lad's operation is you divide that layer. That is what I'm trying to show out here, okay? So you divide that layer, and you can actually then get this, get a fair bit of distance between the cecum. You need to make the cecum go on to, so we've cut the lad's band, we've done the anterior dissection so that the cecum can now slide down. Not the end of the operation, because you have to do something else. Anybody tells me what's the third part of the operation, and it's a very critical bit of it.
Appendectomy.
Absolutely. Bang on. So you do an appendicectomy. Why? Because now don't forget the appendix lie in a weird position. It's rising in the mid-abdomen. For all you know, that might be the position of the umbilicus. And the patient comes in with pain just to the left side of the umbilicus and you are in a problem. What is the diagnosis? So you don't take a chance. Lat's band are cut. Anterior part of the peritoneum is cut so that the cecum and the ascending colon can drift away from the duodenum. You don't want an adhesion forming, and you do an appendicectomy. And this is the man who described. He's William Ladd. And do you know, he was the chief of the Boston Children's Hospital, and his experience was gained treating patients at Halifax, Canada, where there was an explosion. This was a French ship that was carrying all the unexploded bombs in the Second World War. That was, anchored in this place called Halifax in Canada. Now you've just seen an explosion in Beirut, isn't it? How many people died in Beirut? General knowledge. Come on, chaps. You've seen it very recently, and that, social media and everything. There were 209 people who died at Beirut. You know how many people died at Halifax? 2,000 plus. And the bulk of the injury was 9,000 children. You know why? Because you remember in Beirut, what happened was the first fire came out and then the explosion happened. The similar thing happened at Halifax, and these children were all, faces pressed against the glass, watching what was happening. And when the flash burn happened, there was a huge amount of damage, both in burns, facial burns to children, and trauma. So that is how Ladd led the team from Harvard. He carried a train, which was almost a 500-bedded hospital, to Halifax, and that was the basis of his experience in pediatric surgery. And he came back as a pediatrician, and he started specializing as a pediatric surgeon. So that, guys, is William Edward Ladd, something to remember. Okay, so he was chief of the Boston Children's Hospital, and he gained immense amount of experience treating patients at Halifax, Canada, after the ship, and the ship was called Mont Blanc, and that, carrying all this unexploded bombs, and that exploded in the harbor. Right. So what you need to realize is that rotation, intestinal rotation, lends itself to the formation of various folds and recesses, leading to internal hernia. So, chaps, Ladd's operation, you're clear about it? Everybody?
Yes, sir.
Because we've purposely left this till last, because this is a bit of a difficult thing, and I will take you through the rotation. So, all right about rotation, 90 degrees rotation first, then the small intestine undergoes an additional 180. So that's 270 degrees of rotation, which is the region that the axis is the superior mesenteric artery. Therefore, the superior mesenteric artery and the superior mesenteric vein travels across the duodenum, across the unsanate process, which is also formed by the ventral part of the pancreas. Clear about that? So we are going on to the internal hernias now. Okay, right. Now, if you know that, the next thing is the presentation. What is the presentation of an internal hernia? It's just features of intestinal obstruction. You can have absolute intestinal obstruction with or without peritonitis, or you could have recurrent intestinal obstruction where the hernia goes and gets stuck and then pops out again. Right. So now, with the formation, with the evolution of a CT scan, there has been an effort at trying to find out, to define, and to delineate an internal hernia before you even operate. But believe me, the most important thing is for you to understand the clinical features. If, for example, you have a patient coming in with an intestinal obstruction with features of peritonitis, and you've got a straight abdominal x-ray which shows intestinal obstruction, and we've been through that. You have dilated loops of jejunum with valvular conniventi, so it's called the concertina effect. You could have the ileum dilated, which is characteristically characterless. Okay, you might even have colonic distension where you have hostrations which are incomplete, that doesn't travel across bands. So if you have those features and the patient comes in with features of peritonitis, how will you manage this? I will first resuscitate the patient. Please, chaps, in an examination, you must talk about resuscitation. I will do a resuscitation of the patient. Then I will try and, if the patient is fit enough, I will go in for extensive tests. If the patient isn't fit enough, I will resuscitate and perhaps even go in for an exploratory laparoscopy or laparotomy and diagnose the internal hernia at the time of the operation. Okay, so that is important. But the evolution of MDCT, and this means that you actually do a triphasic CT. There's a reason for that. Let me work it through and then I'll explain to you why. See, the moment you have an intestinal obstruction, you have an intestinal closed loop. And when you have a closed loop, you have a feature like this. It forms a beak, because don't forget that you must have the basic principle of an internal hernia is that you have a narrow opening through which the bowel has gone. So you have a beak. You must have a beak. And that is the first thing you have to diagnose, that this is an internal hernia on a CT scan. You need to identify the hernial orifice. And here's where triphasic CT scan comes in very useful, because if you can identify the main blood vessel traveling across, you can, with a reasonable degree of confidence, say that what type of herniation, where the herniation is. But it's not always very clear. You also have two types of hernias. You can have a hernia where let's suppose we have a membrane like that. Let's suppose you have a hole completely, there's no peritoneal covering, so you don't have a sac-like feature. Okay, whereas if, now I'm going to draw out this thing for you in profile. Let's suppose you have two layers of peritoneum, and now you have a hernia going through. The hernia goes through. You can have one layer of peritoneum because the gap was in that, or you could have two layers of peritoneum, or you could actually have nothing because there was a big gap in between. There was a big gap out here, and as a result of which now you have a hernia without any peritoneal covering. So you have the intestine traveling across without any peritoneal covering. Okay, so that is what is described in this picture. So that is without any peritoneal covering. That has a peritoneal covering which can be one or it can be two covers. Okay, right. Is that clear? I know I'm taking you through to very high levels of surgical discussion. So tell me if I need to go back, I'll go back and discuss it with you again. Is that clear?
Yes, sir.
Okay, right. So now, the other thing that happened was, I told you about the vessels. So here's where I'm going to take a bit of time and draw. Let's suppose you have it through the gastrohepatic ligament. So what are the vessels out there? Let me draw the stomach first. That's the stomach. Okay. And the liver is here. Okay. So what is the vessel that lies across? You could have either the left gastric vessels or the right gastric vessels. Now that hernia, if the hernia is throughout here, you need to be able to identify the right or the left. This is the left gastric and this is the right gastric. If you have a hernial beak, let's suppose you have a hernial beak out here, and you can then identify that the left gastric and the right gastric is below out here. You can with a reasonable degree of confidence say that this is a lesser omentum hernia. Okay. You also have a hepatoduodenal ligament, and this is the hepatoduodenal ligament. What lies in the hepatoduodenal ligament? This particular, there's an artery that gives off this, which is the right gastric. It gives off another vessel which travels out here called the gastroduodenal. It goes up out here as a hepatic artery, and traveling with the hepatic artery are two other structures. You have that color traditionally in green, that is a common bile duct, and you have a bluish structure, that is the portal vein. Okay, so lying below this is a foramen, and that foramen is called the foramen of Winslow. So hepatoduodenal ligament, hepatic artery, portal vein, and the bile duct lie in front. Now the greater omentum, let's look at the greater omentum. The greater omentum lies from there, below which you have the transverse colon. I'll draw it hatched because it lies behind. Now you have some blood vessels traveling down the greater omentum. What are the vessels traveling down? Where do they arise from, these vessels? Where do these vessels arise from?
So gastric.
Very good, excellent. The right and the left gastroepiploic. That's right gastroepiploic. That's the left gastroepiploic. Right gastroepiploic comes from the gastroduodenal. The left gastroepiploic comes from the splenic, isn't it? Okay, right. You have also, these are the omental branch of the left and the right gastroepiploic vessels. You also have a ligament out here which leads from the umbilicus right up out here, and that is called the falciform. Very good. It's called the falciform ligament. And what does it contain? It contains the obliterated umbilical, okay, obliterated umbilical vein, and it drains into what? Somebody said that. Very good. What does it attach to? The left branch of the portal vein. Very good. And you also have the paraumbilical veins traveling around and the falciform artery. You also have the small bowel mesentery. If I were to draw the small bowel mesentery, let me, I've lifted up let me just wipe that off. So now we have the small bowel out there. So that's the DJ flexure, and that is the small bowel heading towards the cecum. So the vessel that actually travels across and goes in out here is the superior mesenteric vessels, isn't it? Okay. You have the ascending mesocolon. The ascending mesocolon is supplied by which? Ascending mesocolon is supplied by which? Ileocolic and the right colic. Right. The transverse colon is supplied by what? The middle colic. It arises from the superior mesenteric and the right and the left branches. Okay. The descending mesocolon. So that's a descending colon. Inferior mesenteric artery. Okay. Including its left colic branches, isn't it? Left colic branches out here, superior rectal, the sigmoid branch, and the superior rectal. Okay. So Coming to the sigmoid, it's the sigmoid and the rectosigmoid vessels and the superior rectal vessels. You also have in ladies, you have the broad ligament of the uterus. And let me draw that out here. That's the uterus. That's the fallopian tube. Uterus, fallopian tube. And you have the broad ligament out here. The broad ligament has what? It has the uterine artery traveling in out here, the ovarian artery coming out here, and that gives a tubal branch. So you have the uterine artery going down below, which ascends out here, and the ovarian vessels coming and giving tubal branches out here. Okay, so therefore these are the landmark vessels. So you need to, if you're doing a triphasic CT scan, you need to be aware that this is what this is the vessel that is in existence out here. So we've had classifications. The first and the most important classification, and believe me, the first internal hernias and the maximum you will see throughout your surgical practice and your surgical life, is post-surgery, or it could arrive de novo. Post-surgery, you know, of the faculty, we have younger members in the faculty who are far more adept at laparoscopic surgery, and we are doing a fair bit. We have switched colonic surgery. We always do laparoscopic right now, and we are proceeding on to stomach surgery as well. But post-surgery, it has a higher incidence of internal hernias. The incidence varies from 0.2% to 9% as your experiences rise in doing laparoscopic work. Your incidence reduces. Why is that? Because let's suppose you've done an anastomosis, and let me just 2 parts of bowel. Okay, let's suppose we've done a right hemicolectomy, and we are bringing up the intestine, the small intestine. We are doing an ileocolic anastomosis, and we are going to do an anastomosis out here. The problem happens is that it is very difficult sometimes, and some people actually forget that you're leaving an opening in the mesentery. So if you're leaving an opening in the mesentery, you can have an internal herniation. It is particularly more important where let's suppose we have, some people prefer to do an anastomosis which is pro drainage. So bring the ileum out here. That's the you've done a right hemicolectomy, so that is the end of the mesocolon, transverse mesocolon, and that is the end of your resected ileum. So now the problem is, how do you join that to that? You can't join this to that way if you've done the anastomosis like that. You can do it where you've done a side-to-side anastomosis with both blind ends facing the same way. But if some people prefer doing this. See, the problem that then happens is, don't forget, you have blood vessels out here. And you also have the left colic, the middle colic out here. So if you're taking a bite, sometimes the bite actually can go through the blood supply, and you'll end up with a bluish looking end of the bowel, which means that you've actually taken off its blood supply, and you have to redo that. So that is the reason that in a laparoscopic, you need to be sufficiently experienced in being able to close that mesenteric defect. If you cannot close that mesenteric defect, you have a higher incidence, and that is where you can't. 9% is a fairly high number of people to have a post-op hernia. Okay, so that is, in a sense, that is what is the issue about internal hernia. So you see the majority of internal hernias you see is that post-surgery, and you often have it occurring de novo, and that is 4% of small bowel, all small bowel obstruction. And that is due to the rotation leaving various recesses, various gaps in the intestine, which then need to, lead to small intestine or large intestine traveling in. Right. So our most famous surgery, which is prone to internal herniation, the Roux-en-Y gastrojejinostomy. And what have been done? We've made a hole in the mesentery, in the transverse mesocolon, just to the left of the middle colic. Let me get the middle colic out here. So that's the middle colic. So that is the middle colic. Right branch, left branch, you made a hole out here and you've gone in. But at the end of the procedure, you've forgotten to close that hole. So what are the hernias that are possible out here? The hernias that are possible out here are as follows. Transmesocolic hernia. So that is your first gap. Next, I've done a jejunojejinostomy. In doing a jejunojejinostomy, I've got the edge of the mesentery out here and the other part. So you have a jejunojejinostomy mesenteric hernia. Because I've been scared, because there was a possibility of my damaging the blood supply out here, I haven't taken proper bites. So now I have a jejunojejinostomy mesenteric hernia. But the one that is often present is, don't forget, you have blood supply going out here. And sometimes some surgeons forget to close that. When you forget to close that, you have what is the traditionally known, the famous Peterson's hernia, and that goes across like that. Okay, so Roux-en-Y anastomosis, three areas, three minefields: the transmesocolic hernia, the jejunojejinostomy hernia out here, and the Peterson's hernia, which goes below the free edge of the portion that you've taken up. It's a free edge which actually goes way up there, because don't forget the blood supply, you maintain the blood supply. So the edge doesn't finish out here. That whole omentum has gone up till there with the blood supply traveling across out there. It's traveled from inside out there. So you're worried, it's a long segment of stretch. You didn't want to take bites out here because you didn't want the anastomosis to have become ischemic. So you've forgotten to take a bite, or you've been careful, left a fairly big enough gap. So that is the traditional Peterson's hernia that then occurs. Okay. Right. The other problem. You've got a lesion out here. You've done a left hemicolectomy. Now, how are you going to anastomose it? If, for example, I anastomose it out here, I bring that down and stitch it up here. So think of the gap, the huge amount of gap that I'm going to leave in. That's the gap in the transverse mesocolon. And there's a huge gap out here, so through which the small intestine travels through. Okay, so that's a recipe for disaster. So how would you manage that? Now, there are a couple of things that have been advised and practiced, and let me show you that. The first thing is, you have the blood supply of the right colon coming from the ileocolic, which ends out here. You have the right colic out here, the middle colic coming, dividing into the right branch and the left branch out here. So right now, what do you have? You have the ileocolic out here, you have the right colic out here, and the right branch of the middle colic vessels. You've tied up the vessel out here. And that is your margin, right? So one of the idea is, and one of the suggestions is, you cut along out here. You make that cecum completely mobile and you twist it in a way that the blood supply doesn't get damaged. You twist it down so that now the cecum goes up and the transverse colon goes down. Okay. And that is what is described out here. So that is how you do it. You reverse it so that now you can bring the transverse colon and rip out and stitch it out here. Think of it, chaps, that blood vessel is actually twisted. So that's quite a risky thing to do. The other option is you bring it down, but you bring it down through the mesentery of the small intestine. That's the mesentery of the small intestine. You make a hole in the mesentery of the small intestine and you bring it through, which means basically that the right free margin that was there, you stitch to this area. Even that is risky because when taking a bite out here, you can very well take a bite through the feeding vessels of the terminal ileum, and that leaves you with an equally immense amount of problems. So both these options are have their proponents. It's been described in surgical textbooks, but I have a better take. It actually, think about it, chaps. When you're in practice, think about it. If you've got basically you're going to remove out here and you remove up till there. So my issue is something else. Why not, if the patient is not a person who has a tendency for diarrhea, why not do an extended right hemicolectomy? Okay. So now what you have is, if you've done an extended right hemicolectomy, all you need to do is bring the small intestine and stitch it up there. Okay. That means, therefore, that you have the sigmoid vessels running out here, the superior mesenteric out here. You have the blood supply from the superior mesenteric going into the terminal ileum. So you don't have a very big gap to close. So you have a smaller gap to close. So you have a small gap out here and you have a small gap out there. So you can close that. So you remove all that, 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 that. Okay. The only problem is, if should you have a patient who is prone to diarrhea, that's going to land you in a bit of a problem, because that patient is then going to have multiple number of stools a day, because that part will take a fair bit of time. It takes about 6 months to 1 year to settle down. Even if it settles down, somebody who's prone to have diarrhea will still have 4 to 5 motions a day, and that patient is not going to thank you for it. Okay. So these are the two places where you have a major problem. The other where you have a major problem is where you've done a gastrectomy. I've shown you the ROUX-EN-Y, where you have the transmesocolon, you have the jejunostomy hernia, and you have the Peterson's hernia. 3, this is the option where you've done a left hemicolectomy, and where you've done a left hemicolectomy, the major problem is getting the right colon down into the sigmoid. That is a major problem. So I've explained to you where in surgery, intestinal resection, you have a major problem in leaving a mesenteric defect. Right. Now, chaps, I would like you to take a screenshot of this. This is the internal hernias in the eras of multi-detector CT, and the basis of the talk that I'm going to give you after this is based on this from Japan, and that was a brilliant exposition on the use of triphasic CT scan. But I'm going to, even though I'm going to go through that, I'm going to leave you with a message at the end. Yep, I think I have that slide. So this is the original classification of internal hernias. 2 surgeons, pediatric surgeons actually, Ghahremani and Meyers, defined the types of hernia, and this was an anatomic classification. They said internal hernias can be transmesenteric or transomental, through the mesentery or through the omentum, which is fair enough. But these are the anatomic classifications: paraduodenal, foramen of Winslow, intersigmoid, pericecal, pelvic, and supravesical. Now, you chaps have plenty to remember during an examination. So, I've got a little mnemonic which you can use. So, the mnemonic that I'm fond of using is this: FIP3S. So, think about it. F is for foramen of Winslow, I is intersigmoid. You have three P's. Three P's is paraduodenal, you have a pericecal, and you have a pelvic, right? And S is not sigmoid, S is supravesical. Okay. So, chaps, take a screenshot of this. That's the original Ghahremani and Meyers anatomic classification. So, any point in time you want me to go back and describe something else, please stop me. So, the modern classification, according to this Japanese paper, was this. Any questions? Okay. They said internal hernias can be through normal orifices. We have one normal orifice, that's the foramen of Winslow. You can have unusual peritoneal fossas or recesses, which means rotation of the intestine, and you'll end up with unusual peritoneal fossas and recesses. Or you have abnormal openings in the mesentery or in a peritoneal ligament. I personally don't find a lot of difference between that, but there we are. That is the classification that this article has suggested. So you have the other classification is in the terms of a peritoneal cover. I told you if you have a fenestrated, it's called transmesenteric, which means that bowel, it has no peritoneal sac, none whatsoever. It's called either fenestrated, or it's the same thing, means it's called transmesenteric. It's called intramesenteric, where you have two layers of peritoneum, only one forms the sac. So you have, it's called an intramesenteric. And if you have both the layers of peritoneum forming a sac, it's called intermesenteric. So transmesenteric, intramesenteric, intermesenteric. Okay, so you might want to take a screenshot of this also, chaps. Okay for me to go ahead? Because now I'm going to go into
intra and intermesenteric difference बताइए ना.
Yeah, sure. Let me draw a portion of the peritoneum then. Okay, so two layers of peritoneum, two layers of peritoneum. Now you can either have one layer forming the sac, not two layers. There was a gap out here in one of the layers of the peritoneum, and you have one layer of peritoneum. That is called intra, T-R-A, intra-mesenteric. Okay, intra. In the other scenario, you have both layers of the peritoneum going. So that is an intermesenteric. Okay. Again, if you have one layer of peritoneum, it's called intra. If you have both layers of peritoneum, it's called inter. Okay, so one is intra, both is inter. Is that clear?
Yes, sir.
Okay, right. So once it's clear, I know it's a bit, but we thought it was important for you to get the internal hernias, because if you're discussing all of hernias, you need to also know that. I know it's difficult, chaps, but bear with me. I'm ready to go slow. Don't worry. I'm here. Right. So let's look at the paraduodenal. What are the paraduodenal hernias? I'm going to go into specific areas now. There are two types of paraduodenal. You could have a fossa formed below the third part of the duodenum. That's called the fossa of, hang on, sorry. That's called the fossa of Walder, okay? Which means essentially when the rotation of the intestine happened, the duodenum, which was supposed to become completely uh, retro, extraperitoneal, still had a gap in out here, which meant if I were to draw the duodenum, sorry, I need another color. If I drew, that is the superior mesenteric vessels. You had the duodenum out here. This is supposed to be completely extraperitoneal, but surprise, surprise, what you had out here was that you had a gap under the third part of the duodenum, and that's called the fossa Walder. Okay. The opposite, if you have, let's suppose you have the.
Sir, it is closely approximate to vertebral body, no, sir?
Yeah, absolutely. Just behind that is the vertebral body. Absolutely, bang on. Good. You have the vertebral body out here. Very good. Okay. I mean, basically, where you expected the pancreas to lie, the pancreas is here, just on top. In the C loop. Okay. Think about it. That is actually the pancreas is lying there, isn't it? Just opposite the vertebra. So you had a gap out here behind the third part of the duodenum. That's called the fossa Walder. Okay, clear? Chaps, I'm now going on to the fossa of Lanzert, which is another paraduodenal fossa. And paraduodenal fossa out here is, you have the DJ flexure out there. Okay, you have the inferior mesenteric vein, which was running in, no, let me choose a bigger thing. Was running in, inferior mesenteric vein sometimes drains into the splenic, isn't it? Isn't it? And in that, you have a fossa just behind the inferior mesenteric vein, and that's called the fossa of Lanzert. You have a fossa out here. So sometimes you have hernias forming out here. So there are basically two types of paraduodenal fossas. One is the fossa Walder, where there's a fossa behind the third part of the duodenum, and the fossa Lanzert, which lies behind the inferior mesenteric vein out here. Okay, can I go ahead? Clear?
Yes, sir.
Okay, right. So next is you have small bowel mesentery. Small bowel mesentery, you have, you have small bowel mesentery. The small bowel mesentery is you have a gap in the mesentery that is normally formed. The small intestine, you're used to knowing that if I draw the small intestine like that, and the blood supply going in there, two areas sometimes are prone to develop gaps, and these gaps can be either intramesenteric or intermesenteric. Okay, remember what I said. Intra means you have a gap in one fold of the peritoneum. Inter means you are traveling through with both lobes of the peritoneum. And where do they occur? Normally near the DJ flexure. That's the first point there. And near the terminal ileum. So there. So it could be a gap, two layers of peritoneum, either one or both. If it's one, you call it intra. If it's two layers of have a gap, and it's called intermesenteric. Okay, so intramesenteric and intermesenteric. Okay, perhaps I know this is tough, but I'm ready to go very slow. Don't worry. Right, oment or lesser sac hernia. Now that is an opening that we all know. That's called the foramen of Winslow. But I want you chaps to tell me what are the boundaries of the foramen of Winslow. That's the foramen of Winslow. What is the boundary? What lies in front?
Gastrohepatic ligaments.
Very good. The gastrohepatic ligaments containing what?
The portal triad.
Portal triad and the C.
Yeah. So you need to tell me what are the parts of the portal triad. What are the three? Hepatic artery,
Portal vein, the hepatic
portal
artery,
vein,
and the
and common bile duct. Okay.
bile duct.
Fair enough. Absolutely. What lies behind? Very good. Yeah. What lies behind?
Inferior vena cava.
Inferior.
Excellent. Wonderful. Great. Well done. What lies on the roof?
Caudate
Inferior
lobe.
surface of the
Caudate lobe. Yeah, inferior surface of the liver with the caudate lobe, isn't it? Okay. But what lies inferior?
Duodenum, sir.
third part of the second.
Pancreas.
Okay. I grant you everything, but one more. There's another structure beside the inferior vena cava, isn't it? What is that structure?
Aorta, abdominal
Aorta.
aorta.
Aorta, absolutely. And guess what? The aorta has given off one branch which travels like that.
Brain mesenteric artery.
Right renal.
No, it gives off that branch and gives off another branch out here. And
Gastroduodenal.
absolutely, that's a gastroduodenal. That is the common hepatic artery, isn't it? So common hepatic has to cross and come in out here to give off the hepatic out here, the right gastric out here, and the gastroduodenal out here. So it has to be forming the floor of the foramen of Winslow, isn't it? Together with the duodenum, together with a bit of the, somebody said, bit of the pancreas. Okay, but principally the most important thing that traverses that is the common hepatic artery, which actually has to cross from the aorta to the duodenum to give off the branches to the hepatic artery, the right gastric, and the gastroduodenal. Okay, so that is your boundaries of the foramen of Winslow. Very good. You also have lesser omental hernias, which means it comes through the lesser omentum, which means it actually comes through the, we've already drawn out the lesser omental hernia, which means it comes through out here, which means it's coming through out there. You have an intramesenteric omental hernia. Now, what is that? Omentum is basically a four-layered structure, isn't it? Four layers. There are two layers going down, two layers coming up. Okay, right. So if you have an intramesenteric defect, which means the hernia has come through out here, and it is in between that and that, in between that and that, where does it present? It has to present in the lesser sac. Okay, so technically, lesser sac hernias are foramen of Winslow hernia. So there, it's come through out here. You have a lesser omental hernia from there. You have an intramesenteric omental hernias from there. You also have hernias coming through. What is that structure? That contains the blood vessels to this particular structure, the transverse colon. So what is that structure?
Mesocolon.
Right, that's a transverse mesocolon related hernia. And finally, you have a combination. Sometimes hernias come through out here and come through out here, or they go the other way. So you have combined hernias. But remember, there are four places through which you can have lesser sac hernias. Number one, let me take the white. Number one is foramen of Winslow. Number two is the lesser omentum. Number three is the greater omentum, but not through and through. If it was going through out here, it wouldn't form a lesser sac hernia, isn't it? If it going through out here, it won't form a lesser sac hernia. If it's an intramesenteric, what was an intramesenteric? There are 4 layers. 4 layers out here. This hernia has gone in through 2 of the layers, but not the 4th. So now you have a lesser sac hernia. Okay, so intramesenteric omental hernias. So that's number 2. Number 3. Sorry, number 2 was lesser omentum. Number 3 is a transverse intramesenteric omental hernias. Number 4 is a transverse mesocolon hernia. So 1, lesser omentum. 3 is an intramesenteric omental hernia, and number 4 is a transverse mesocolon related hernias. So there are 4 types of lesser sac hernias, and 5th is a combination hernia. Now, if you have a hernia through the omentum, it could, as I said, it could be right or left transomental, which means basically, if you roughly divide the omentum into 2 parts by basically the central blood supply, it could either be the right or the left. In this situation, you have a hernia which has gone through all the layers. You have to, even if it is 4 layers, it has gone through all the layers, which means that your hernia has gone through usually from behind all the way up out there. Okay, so it would have definitely, where there are 4 layers, it is either intramesenteric or intermesenteric, depending on whether they have out here 2 coverings or 4 coverings. Okay, so if you have a 4 covering, so all 4 layers coming out means it's an intermesenteric. If you have 2 layers coming out, so that layer coming out, it's called an intramesenteric defect. Okay. All right, for me to go to the next one? Or do you want me to go through this again?
No, sir, understood.
Okay, right. Next one. Right. Paracecal hernias. Paracecal hernias, don't forget that the cecum has traveled, it's like Marco Polo, it's traveled a long distance. It's traveled from the vital intestinal duct, traveled in out here. So you have hernias occurring at basically 4 places. You have suprailial, infraileal, you have retrocecal, and you can have a that somebody needs to mute your connection. Okay, so 4 hernias: suprailial, infraileal, retrocecal, and paracolic. So 4 lesions where you could have a hernia. The only difference being that if you have a supra and infraileal, it is normally associated with this blood supply. What is that blood supply?
Ileocolic.
Yeah, the ileocolic. So it could be either above the ileum or below the ileum. If it's retrocecal, you don't have any blood supply out here, but you have something else. There's something that lies behind.
Ureter.
You can't pick up the ureter. There's another muscle that
So yes,
lies on.
yes, Manju.
Swas.
Psoas muscle, very good. Remember Cope's psoas test. If the appendix was retrocecal, you have a Cope psoas test, isn't it? So if you have a hernia between the cecum and the psoas, it has to be retrocecal. Okay. If it is lying lateral to the cecum, then it is a paracolic hernia. Okay. Right. So superior, if it was above the ileum, it is related to the ileocolic. Below, it's also related to the ileocolic, which has traveled out here. Behind retrocecal, it is lying between the cecum and the psoas. And paracecal, it lies lateral to the cecum. Okay, so 4 areas of a paracecal hernias. Okay. Right, sigmoid mesocolon hernias. Now, if you have a sigmoid mesocolon hernia, it goes through the mesocolon, which means it travels in between the branches of which vessel? Which is the vessel that is out here?
Inferior.
Inferior mesenteric with its left colate, the sigmoid branches, and the superior rectal branches, isn't it? But in a CT scan, there's something else that you need to be aware of. Like the cecum, what lies behind the sigmoid? The psoas, the left psoas. Okay, so think about it. You had this lying in front. Now when the hernia goes through out here, it is related to the branches of the inferior mesenteric, but lies between the sigmoid and the psoas muscle. Okay, so that is a sigmoid mesocolon hernia, and in a sigmoid mesocolon hernia, here is where the original definition of the term intramesenteric and intermesenteric came in, because this is notorious. Here you have all 3 varieties. You have a transmesenteric, you have an intermesenteric, and an intramesenteric, depending on whether they are, there's a complete hole, whether you have a hole with one part of the omentum, one part of the peritoneum, or whether you have both parts going in. Okay, so you have the entire gamut of transmesenteric, intermesenteric, and intramesenteric.
Sir, any reason, sir, entire gamut occurs here?
Sorry?
Any reason?
Entire gamut means no, it's just that the sigmoid mesocolon stretches out quite a bit. Think about it, chap. You know, if you have a sigmoid mesocolon, you have somebody who's constipated. Okay, so the reason you have that entire gamut is, let's suppose you had an initial sigmoid like that. Now this patient, elderly patient, lifetime of constipation. So what now happens is that the sigmoid colon stretches all the way out here. Okay, so what stretches together with the colon? It's not just the colon which is stretching, isn't it? You have that entire mesocolon stretching as well. And when you have the mesocolon stretching, you sometimes land up with gaps, either complete gaps, partial gaps, or pouches. So trans, intra, and inter. Okay, that is the reason a sigmoid mesocolon has, you know, there was a time when, you know, when we were initially starting off this practice of GI surgery, you were expected to do your own colonoscopy. And believe me, when we were initially in training in the UK doing the colonoscopy, there have been occasions when my entire colonoscope went in and all I reached was the sigmoid descending junction. So you actually had perhaps a colonoscope going all the way up, all the way up, coming down, and all you've done is reach that area where the descending colon, and so the sigmoid was that bit, almost up to the epigastric region. Okay, so the sigmoid extends it. That is the reason that you have a volvulus of the sigmoid, isn't it? So common in life, you have a sigmoid volvulus, right? Okay. Falciform ligament hernias, it's almost always transmesenteric, because if you have a hole out here, it travels all the way across. Very rarely do you have an intra, but the peritoneal covering isn't out there. So you have a hole going all the way across from the right to the left, or the left to the right. And the usual diagnosis is you have that beak, you have an obstructed hernia, you have a beak, and that lies in front of the liver, like you would in another condition where the colon lies in front, where the falciform is slightly weak, and it's called Chilaiditi's syndrome. Okay, except here you must have a beak and features of intestinal obstruction. In a Chilaiditi's syndrome, you have the colon lying in front, normally where the falciform ligament is weak and it's attenuated. In a hernia, you have it traveling across, so you have a beak-like formation with features of intestinal obstruction. So there we are. So that's a falciform ligament hernia. Then we have the other important part is the pelvic internal hernia. The pelvic internal hernia, and I think Dr. Rudrajit Sinha has taken you through, he's done a beautiful presentation of the different ligaments. So I'm going to ask you, first, let's look at the uterus related hernias. You have the broad ligament hernias. It could be through the broad ligament, through the entire broad ligament. So it's a trans broad ligament, and it's fairly common. I've often been called over by gynecologists who have diagnosed this at the operating table, and you have a gap in the broad ligament. The thing with the broad ligament is that the two vessels that you need to, the CT scan can define. And what are the vessels? There's one vessel which comes in out here.
Ovarian.
Okay, and another vessel that comes in from here. What is that one? Uterine. The uterine vessel comes in lower. The ovarian vessels and the tubal branch, and its tubal branch lies on top. Okay, so it travels in between these two vessels, the tubal branch of the ovarian and the uterine, which comes in from below. But you also have an internal supravesical hernia. What is that internal supravesical hernia? Let me find out whether you remember from Dr. Rudrajit Sinha's talk. You have, firstly, in green, that is the bladder, and you have that ligament. Sorry, it's not very prominent. Hang on. Let me choose another color. Let me choose that color. Yeah, I think that will. You have a ligament out here. What is that ligament? If you look at the...
Median.
Yeah, okay. Median umbilical ligament. Okay. What is the next structure that you have out here?
Medial.
And what is the medial? What is the medial?
Umbilical arteries.
Okay, umbilical artery. And where does it end?
Umbilicus.
Okay, right. On the top umbilicus. Absolutely. Grant you that. But other end, where does it end? That was a very good answer. I must be honest. Sorry, yeah. The proximal part of the obliterated umbilical artery does not completely obliterate. It represents what? The superior vesical artery, a branch of the internal iliac. Okay, remember that. Okay, right. So what lies from here? So we've had the median, we've had the medial. That is the lateral. Okay, so what is that? Lateral is what?
Inferior epigastric.
Very good. Inferior epigastric. Okay, right. Yeah, very good. So now if you have a hernia, you can't have a hernia in between the median and medial ligament. If you have a hernia out there, what will it, where will it go?
Supravesical.
Yeah, internal supravesical hernia, but it goes into which space? Let me draw it out for you in.
Red GS space.
Very good. Excellent. Excellent. That's what I wanted to hear. Very good. Good. So you have, let me draw the, that's a symphysis pubis. Okay. Right. And that was the bladder with the uricus. Okay. And this is the space in which the hernia occurs. So it occurs in the space of Retzius, isn't it? But it should always go down below. Internal opening, it should go down below. Why? Because it should extend down this way. What happens if it goes up? It's no longer called an internal hernia. Why?
It will come out through the umbilicus and umbilical hernia.
No, it doesn't come out through like this. Okay, let me just draw. That is the picture. I'm drawing that in coronal section. So that is the symphysis pubis. Okay, that's the superior ramus out here. There is, I'm drawing it from the front. There's a ligament that goes in out here.
Ilioinguinal ligament.
Yes, that's ilioinguinal ligament. And you have another ligament which has a slightly curved margin. That is called the what ligament?
Lacunar.
Lacunar ligament. Right. And below that, you have also another fascia which is called the pectineal fascia. Okay. You have out here a vessel which is blue out there, and you have another vessel out here which is in red, and you have something in yellow which is lying flat. So what are these structures that I'm drawing? That's the
Femoral veins.
very good. That's a femoral nerve.
No.
That's a lacunar ligament. So think about it, chaps. If it has gone inside, if it has progressed inside, you know, it's gone down below, behind that, it's called an internal supravesical hernia. Okay. If it goes up, sometimes it comes through the pectineal ligament. It forms an unusual hernia, and I'm sure Dr. Ramanuj Mukherjee has told you about it. Or it can come through the lacunar ligament. You've already forgotten what Dr. Ramanuj Mukherjee has told you. What is this hernia called? What is this hernia called? Rare hernias. This is called Logier's hernia. Okay. And this is classically called the pectineal hernia or the Clausen cloacae hernia. Okay, that comes through the pectineal ligament. So you have to remember, internal vesicle goes down below. If it comes up, that is the area of, sorry, no, sorry, I won't draw it in that color. Sorry. I will draw it in the same color that I used out here. That sheet is the lacunar ligament, okay? Below is the pectineal ligament. So if it travels up, think about it, chaps, if it travels up, if that hernia travels up and comes through the pectineal ligament, it's called the pectineal hernia, or it comes through out here, it's called the Loggia's hernia, okay? So Loggia's hernia or the pectineal hernia, right? Sometimes you have very, very, very rarely, you can have a hernia through the pouch of Douglas, which meant that's your uterus with the vagina out here, and you have the rectum out here. Sometimes you have a hernia going down below. It's very rare, but you can have a hernia coming out as a sort of a pelvic hernia through the pouch of Douglas. So that completes, in a sense, the internal hernias that. Okay, but the critical points. Internal hernias presents with features of intestinal obstruction. The clinical scenario will dictate the treatment. If you have a patient who has peritonitis, please don't waste time at going in for a diagnosis. You've got a hernia, you go ahead and you need to do something about it. But why you need to know where the internal hernias are is that sometimes, and sometimes that is the critical bit, you have a hernia out here. Let's suppose that's come through the foramen of Winslow. What lies in front? You've got the hepatic artery in front, you've got the bile duct beside it, and even worse off, you've got the portal vein in front. Okay, you have the IVC running behind. So you need to know what are the important vessels that are there. You have the common hepatic running just under there, giving off the branch, the hepatic branch out here, the right gastric out here, the gastroepiploic. So it's very important to know where the blood vessels are. So that is the most important thing. Diagnosis is often made at exploration. Of course, multi-detector CT, and this paper, I hope you've taken a screenshot of that. You go through that because that comes out with beautiful CT scan images. Multi-detector CT can help in pre-op diagnosis, but the treatment, whether you like it or not, stays the same. You resuscitate the patient, and this patient needs an exploration. The only difference, and the critical difference, is you need to know your anatomy throughout, and that is why I spent such a lot of time on the anatomy, because you can't, I mean, if you have an obstructed indirect hernia, you can't divide the neck of the sac medially, because if you divide it medially, what will you divide? You will divide the inferior epigastric, isn't it? So you need to know where your vessels are, and that is the prime thing for internal hernias. Okay, right. Final slide. Be aware that at 4% you may face it in the course of your surgical lifetime. The most important thing is to remember your anatomy when you're handling internal hernias. Right, chaps, any questions?